Our next speaker is Lisa Muehmel. She is our Certified Elder Care Coordinator at Mannor Law Group. Lisa has extensive knowledge of federally funded healthcare programs and has conducted numerous trainings and presentations on this topic. Before joining us, Lisa worked for the Area Agency on Aging 1B in the role of the Medicare Medicaid Assistance Program Site Coordinator, a lot of us know as a MAP coordinator. Today, she still volunteers for 1B as a MAP program counselor. Lisa has put a great deal of time and effort in today's presentation on Medicare 101. Please help me welcome Lisa Muehmel. Is this good, or do you want the lapel?
It's good.
Okay.
Good morning. Can everybody hear me okay? That a little bit better? I can't move around like Bob does. I have to have my notes with me. So we're going to talk a little bit about Medicare today, but before we jump in, I kind of want to get a sense of where you are in the audience with your comfort level with Medicare. So with a show of hands, how many people here today feel like they have a pretty good handle on Medicare? Anybody? Quite a few, all right. How many feel like Medicare is a complete mystery? All right, and then the rest of us somewhere in the middle. All right, well, let's jump in and see if we can learn a little bit today about Medicare. All right, so starting with the basics, what is Medicare? So Medicare is health insurance for three groups of people: those 65 and older, those under 65 with a disability after a 24-month wait period, and then any age with end-stage renal disease. Medicare is administered through the Centers for Medicare and Medicaid Services. We'll refer to them as CMS. Enrollment, though, is handled through the Social Security Administration for most. From some who retired from the railroad, they'll go through the Railroad Retirement Board. So when we enroll in Medicare, a lot of people assume that the federal government knows when we're turning 65, so they'll automatically enroll us. And that doesn't happen unless you are taking your Social Security benefits early, or your railroad retirement benefits. That's going to be the only time that you're automatically enrolled into Medicare. And if you fall into that category, your initial package is going to be mailed to you 3 months before your 65th birthday or 3 months before your 25th month of disability. For the rest of the world, who's not automatically enrolled, you have to do something. So if you're not receiving your Social Security benefits or your railroad retirement benefits, you're going to need to visit the Social Security Administration and actually choose an enrollment. You can do that by visiting the office. You can call their 800 number, or you can go online. Social Security would prefer that you go online. So when do we enroll? You don't have to be retired to enroll in Medicare. So if you're still working and you want to take premium-free Part A, you can do that before you retire. But your initial enrollment period is a 7-month window. It starts 3 months before the month that you turn 65. It's the month that you turn 65 and the 3 months after. There are other times throughout the year that you can enroll, but if you delay enrollment, you may find yourself in a penalty situation if you don't have other coverage options. So there are penalties attached to Part A of Medicare, Part B of Medicare, and Part D of Medicare. We'll talk a little bit about that. So once you get your card, if you are wanting to accept both Parts A and B of Medicare, you keep your card, you start using it, you're enrolled in Medicare. If you are, for example, still working and you don't want Part B just yet, you follow the instructions on the back of your card, mail it back, and they're going to send you a card that indicates what part of Medicare you are enrolled in. A lot of you may be familiar with the idea that they issued all new Medicare cards. So our old Medicare cards had our Social Security numbers on them, and that caused a lot of fraud. So, and identity theft. And so they've issued new cards now. Everybody should have their new card. No longer has your social security number on it, no longer has your gender, and no longer requires a signature. All right, so how does Medicare coordinate with other benefits? Medicare does work with other forms of benefits, but not all. So if you're still employed or your spouse is still employed and that employer has 20 or more employees or 100 or more employees if you're disabled, that group health plan is going to be primary to Medicare. Medicare is just kind of dangle out there. You're not really going to use Medicare while you still have your group health plan coverage. If you are one of the lucky ones who has retiree coverage, Medicare is going to be primary because retiree coverage is not considered creditable coverage. And what that means is it's not considered as good or better coverage than what Medicare offers. So you would have to take Medicare there. For those people who are federal retiree or receiving federal retiree benefits, you can have and probably should have both Medicare and we call them FEB benefits. They do work together. If you decline getting into Medicare and only have your federal benefits, you can be in a penalty situation later on if you decide you would like to enroll in Medicare. Then we have TRICARE. So TRICARE is health insurance for people who are active military. And if someone is still active in the military and they age into Medicare, the two will work together. We also have TRICARE for Life, which is not on our slide. That is for people who have retired with at least 20 years of service from the military. Then we talk about COBRA. So COBRA is both confusing and expensive. So I have to read this one because it doesn't stick with me. But if you have COBRA, when you become eligible for Medicare, you have to get Medicare. But conversely, if you have Medicare and then you become eligible for COBRA, you can have both. Now, the only time that I've seen it make sense is somebody who was taking a very expensive drug that was not covered by Medicare. And so the cost of COBRA and Medicare made sense to them. So they went ahead and had both. But most times, people are not really going to want to have both COBRA and Medicare because of the cost. Then we talk a little bit about VA benefits. Some folks will opt to just have their health insurance through the VA, and that's fine as long as you're scheduling an appointment. But if you are at home and you have a heart attack, the EMS is going to take you to the closest facility, and that may not be a VA facility. So typically the way this works is VA works within their hospitals and clinics, and Medicare likewise. So it's a good idea with VA to have both benefits. All right, so the 4 parts of Medicare. Start with Part A, which is our hospital insurance. Part B is your medical insurance for your outpatient doctor's visits, tests, procedures. Part C, we should probably call it what it is, a Medicare Advantage plan. These are managed care options that are structured like an HMO or a PPO. And then we have Part D, which is our prescription coverage. So when you become eligible for Medicare, you have a couple of options for receiving your benefits. The first would be through original Medicare or traditional Medicare, and that would be Part A, Part B, Part D, and then some folks will opt to purchase secondary insurance called a Medigap plan, and that would kind of complete the original Medicare side. We tend to say that this is the more conservative side because all your bases are covered. You really don't have additional out-of-pocket costs other than premium. Then we also have the managed care option, which would be our Medicare Advantage plans. Those roll all parts of Medicare together, but you will always have copays and deductibles when you're in a Medicare Advantage plan. You're also going to be dealing with networks of doctors and providers, so there's somewhat limiting in that regard. So we'll go a little further into original Medicare. We talked about Part A being our hospital insurance, so that covers you in the hospital, in a skilled nursing facility, It also covers home health care, and Part A also covers our hospice benefits. Part B is our medical insurance. We mentioned that that is for our outpatient doctor's visits, tests, procedures. Noteworthy is that there are penalties attached with this. So if we're eligible to be enrolled in Medicare, we opt not to be enrolled in Medicare, and we don't have other coverage, there are penalties. We don't see the Part A penalty very often, but we do see the Part B penalty. And what that is 10% of the Part B premium for every 12-month period that you could have been enrolled, but you chose not to be. So if you go a full 12 months without coverage, you will be in a penalty situation, and your premiums will go up. Okay, we're going to talk a little bit about the costs of each section of Medicare. So it's good to start with an explanation that Medicare Part A is broken into benefit periods. So a benefit period starts when you enter the hospital, and it ends when you've been out of the hospital or a skilled nursing facility for 60 consecutive days. So for every benefit period under Part A, there's a deductible. And this year, it's $1,364. So what this means to the beneficiary is, first day you go into the hospital, you pay the $1,364. You get a little better, you go home. You're home for 60 days, you get sick again, you go back into the hospital, you pay $1,364 again. So that one is a repeating deductible that you have to pay potentially multiple times. But anyways, with the $1,364, you're covered for the first 60 days. If you're really sick and you can't get out of a benefit period, days 61 through 90, you pay $341 a day in copays. If you're really having a bad year, days 91 through 150, you pay $682. So it can be really expensive if you don't have secondary insurance, which we'll talk about. We know that we can go to a skilled nursing facility under that Part A deductible for 20 days at no cost. We can then stay days 21 through 100 if we need to, and there'll be a copay of $170.50 a day. Beyond 100 days, there isn't any additional coverage. Home health care has a benefit under both Part A and Part B. So under Part A, you can have up to 100 visits at no cost. If during that time you require some durable medical equipment, there is a 20% copay. Hospice, of course, is covered under Part A, and there are very little out-of-pocket costs for hospice. We do really like that benefit. There are some costs for some of the palliative drugs. And then somewhere along the line, Congress decided to enact a blood deductible. Somebody thought this might be a cost savings effort for Medicare, and it never really panned out that way. But what this says is you can have as much blood as you need, but Medicare won't pay for the first 3 pints. So no real savings there, but that was a plan. So for most people, Part A comes to them premium free. That's based on their work history that they paid into the Medicare tax. So if you work 10 years or 40 quarters, Medicare Part A comes to you premium free. If for some reason you didn't have that kind of a work history, maybe you were a housewife or something to that end, if you have 30 to 39 quarters, you can buy Part A at $240 a month. If you had from 0 to 29 quarters of work history, you can buy Part A at $437 a month, so it's not cheap. So we'll talk a little bit about Part B. Part B also has a deductible, but it's a one-time deductible, and it's only $185 this year. So of course, the big one is repeatable. The little one, we only pay once. The way that Medicare is set up is it's an 80-20 system. So Medicare pays 80% of the cost of your Part B services. The beneficiary is responsible for the 20%. Then we have our clinical laboratory tests. We have that home health benefit again. We have our outpatient treatments, which will have a 20% copay. the blood deductible again. So they upped it a little bit on this one, and they said, we're not going to pay for the first 3 pints, and we'll charge you 20% for any more that you need. But of course, you can get as much blood as you need. We also have, well, let me talk a little bit about costs. So for this one, most people have their Part B premium deducted from their Social Security check. This year, that's $135.50. There are a small percentage of people out there that will pay less because there is a rule built into Medicare called the hold harmless rule. And what this says is a person cannot have a higher premium than what they were given in a Social Security increase. So one hand can't take away what the other didn't give, basically in this. We also have a group of people who are our higher income individuals. So we'll talk a little bit more about this issue later, but it's called the income-related monthly adjusted amount. So those higher income folks who maybe cashed in an IRA, had an inheritance, or just simply have a higher income, they're gonna pay a higher Part B premium and a higher Part D premium. But we'll talk a little bit about that in a little bit later. Okay, so you guys have probably heard about this, but when it comes to facilities billing, they get a little bit nervous about continuing care when someone is either plateauing, back to their baseline, not showing improvement. So there is a settlement called Muehmel versus Sebelius that I want everyone to take note of. So a criteria for continuing needed care is not that you are showing improvement, okay? So we want people to be really aware of that. You do not have to be showing improvement. This portion of it is dealing with the home health care. So if someone still requires some home health care, they can continue to get that under Part B, even if they're not showing improvement. They have to be homebound, which means that they can't leave home by the usual means. They need some assistance. The physician has to order this. They have to require a skilled care, and there's no improvement standard. That's really the takeaway I want for you guys to have here. They have to receive this service through a Medicare certified home health agency. Then we also talk about this in terms of a skilled nursing facility. So again, we don't have to have patients showing improvement. They just have to need ongoing care to maintain the level that they've reached. So let me give you an example. We had a client who had a condition that was not well known. Doctors weren't real clear on this condition, and we weren't real sure about it, but it was called transverse myelitis. And in the research that we did, what we did find out is if this person did not have continuing physical therapy, we were basically going to be putting them in a wheelchair. So we pushed back because the facility really wanted to move this person to their long-term care area and give them just restorative therapy, take away the PT. But the reality was that this person was motivated and really did need the therapy. So we pushed back. The facility reconsidered. That person is still receiving therapy today under Part B, still receiving that physical therapy. So it does work. Medicare has not declined any of the claims. They're getting paid. It does work. All right, so then we also have the issue of observation status versus hospital admission. So if a person is at the hospital under observation status, Medicare will be billed under Part B, and they're going to have those copays, that 20% copay. If they're admitted into the hospital, they're going to have that big hospital deductible, but they're going to be billed through Medicare Part A. So some of the issues that arise are, excuse me, they're going to have that big Part B copay, all right? That can be a problem. But the bigger issue as we know it is that without that hospital admission, they can't go to a skilled nursing facility for rehab, and that's a big concern. Their prescriptions are handled differently, but that's not a real big one. It's either the prescriptions are covered under Part A or Part D. Not a lot of cost difference there. But there are a couple of rules that are built into Medicare, and one you may have heard of is called the 2 midnight rule. And what that says is if a person is sick enough to be at the hospital for 2 days, rule of thumb is the provider should admit them, all right? So problem here is it kind of is a rule of thumb, but we can push back on that. There's also the MOON notification, if you've heard of that. That's the Medicare Outpatient Observation Notice. And so if someone is in the hospital under observation, the hospital is required to have them sign a form letting them know that they are under observation. And then when we have that conversation, we can kind of push back and say, all right, why aren't they admitted? We're pushing for admission. So those are a couple of things that have been added that seem to help a little bit. So as part of the Affordable Care Act, which we're still dealing with now, that may change, but we still have that in place now, Medicare offers some preventive services. So these are covered under Part B of Medicare. They're covered through original Medicare, also through the Advantage plans, and then some of our other plans like a private fee-for-service plan. The idea behind this was that if you have some health issues, they'll be caught early on. You'll have better health outcomes, there'll be lower costs to Medicare. So it seemed to be working that way. So the way that we pay for these preventive services, for those individuals who are in original Medicare, there really isn't a cost. You go for those services in the periodically as they're offered. There shouldn't be an out-of-pocket cost. But for those who are in Medicare Advantage plans, we know that there's a 20% copay for every touch with a medical professional. So every time they go to a doctor, whether it's for one of these preventative services or not, they're going to have a copay. So this is kind of a chart of what you can get, a little bit of what you can get and how often it's offered. We can get their cardiovascular screenings, breast cancer screenings, colonoscopies as we go down. The one that garnered a lot of interest when this first came out was the Welcome to Medicare visit. So this is a one-time thing. When you're new to Medicare within the first 12 months, you can go in. People thought this was going to be a physical, and they were kind of excited about that. I'm going to get a free physical. But as soon as this visit becomes diagnostic in nature, there's a cost. So all this really is a review with a medical provider of your current health conditions and maybe some suggestions for future screenings or preventive measures that you can take. So this really isn't a physical, it's not diagnostic. Same thing with the yearly wellness visit. So once you've been on Medicare for a year, you can go for a yearly wellness visit, and this is just kind of updating what you've already talked to them about. So say you're a diabetic. They're going to ask you kind of the things that you're doing to manage your diabetes. They're going to make some suggestions, but it's never a physical. All right, so I talked a little bit a minute ago about people maybe wanting to purchase supplemental insurance. So it's called supplemental insurance or Medigap. And these are policies sold by private companies. They fill the gaps of original Medicare and only original Medicare. So they cover those deductibles, the coinsurance co-payments. So we know that we have that $1,300 deductible when we go to the hospital. So if we purchase a supplemental insurance, that'll be covered. These plans are all standardized except in 3 states. So they're standardized here in Michigan. What that means is every plan A, for example, that you would purchase is going to offer you the same coverage as any other plan A. They're going to charge you differently, and it'll be a different carrier, but the coverage is standardized. The downside about these is that they're not all offered to people who are under 65 and on Medicare due to a disability. So we've kind of forced some of our disabled individuals into an Advantage plan until they turn 65. These are optional plans. There are never going to be penalties attached to these, but there are going to be times when you can purchase them and when you can't. So we'll talk about that. So as you can see, the standardized plans are named by the letters of the alphabet, and here they're not sequential. And the reason that they're not is because over the years, Medicare has added additional benefits which made some of these Medigap plans obsolete. So they stopped selling them. People who were in them could stay in them, but you can't purchase them any longer. These plans are rated. There are 3 different rating methods: community rated, issue age rated, and age attained rated. So community rated products are the most cost effective for our beneficiaries, okay? But we only have one in Michigan currently, and that is an AARP plan through United Health. A lot of people will opt for that because it is a community rated plan, and what that means is everybody who purchases that product pays the same amount. It's not based on your age. The majority of the plans that we have are going to be age attain rated, and that doesn't always work out well for the beneficiary in the long haul, because as you age, your premiums will increase, and when you get to the point where you probably are the sickest, your premiums are going to be pretty high. So there isn't an enrollment period for this, and what happens is when you are first on Medicare, let's qualify that, so when you're at least 65 and you have Part B, so when those 2 things happen, you have a 6-month window to purchase one of these products without being medically underwritten, without being denied coverage excuse me, based on your health. So that's the time that you really want to take advantage. You can purchase one of these products anytime that they'll sell it to you. But as Bob mentioned, you can't get homeowners insurance when your house is on fire. You're not going to be able to get one of these after a cancer diagnosis or diabetes or some of the other health conditions that we see in our seniors. So you really want to take advantage of that 6-month window if you're able to. So this is a chart of the structure of these plans. So you can see Plan A doesn't offer as much coverage as some of the other ones. What it doesn't cover that's concerning to some folks is it doesn't cover that big hospital deductible. So what we have seen in the past is folks who are on Medicaid and having trouble finding doctors may purchase a Plan A, and that allows them to go to any doctor that accepts Medicare. So if they can scrape together the money for the premium, and Plan A premiums are going to be lower, that seems to be the people that this works for. We used to say that Plan F was the Cadillac of all plans, covered everything. That's still true in 2019, but as you'll see in a minute, they're changing that. So really, one of the main differences between F and some of the other plans is what's called a Part B excess charge. And this is really just a self-limiting charge if you go to a doctor who participates in Medicare but doesn't accept Medicare's assignment or their approved payment amount, they're allowed to charge 15% above Medicare's approved amount. So that can be a lot or really not be a big issue at all. So Medicare is a very fluid program, changing all the time. So changes are coming in 2020, and they will no longer be selling Plan C and Plan F. If you're in those plans, you can stay in those plans. But what do we know about insurance when the insurance pool shrinks and the people in that pool get less healthy? Our premiums are going to increase based on that information. So you can stay in it, but as that pool continues to shrink of people who are in that product, premiums are going to be kind of exorbitant. So the idea behind this was they want everybody to have a little skin in the game. So no plan is going to be sold that covers the Part B deductible, so that $185. So Plan C and F covered that $185, and that's why they won't be sold any longer. All right, talk a little bit about Medicare prescription coverage. This is available for all people with Medicare. You don't have to have both parts of Medicare. You can have A or B. This is provided through standalone prescription drug plans, some Medicare Advantage plans, and some of the other plans that are out there. One of the rules built into this is that each plan has to cover at least 2 drugs in every Medicare approved drug category. So that means that your doctor can prescribe a drug, and it may not be on the list of drugs covered by your plan, but there are going to be at least 2 other options out there. And then there are some protective categories that I'll read to you. So there are 6 protected categories in which each plan has to cover all drugs. And that's cancer meds, HIV/AIDS treatments, antidepressants, antipsychotic meds, anticonvulsive treatments, and immunosuppressants. So every plan's going to cover all the drugs that deal with those issues. Okay, so we say this is optional coverage, but we have to understand that if you opt not to get this coverage and you don't have other creditable coverage, let me emphasize that, you don't have other coverage, then you opt for a penalty, all right? And that penalty is going to follow you for as long as you're enrolled in a prescription drug plan. So it is optional, but you get stuck if you opt not to have it. This is provided by private insurance companies. You have to choose and join a plan in most cases. Some folks are auto-enrolled, but that's rare. Plans have formularies, I mentioned that, and the formulary is the list of drugs that they cover. You have to pay a monthly premium, and there's going to be co-pays and deductibles. This is what the structure looks like. As you read it, it's a little confusing, but each plan is allowed to charge a deductible. This year, the maximum deductible is $415, so that's the most that they can charge. Once that deductible is met, our beneficiaries go into their partial coverage phase where they pay 25% of the cost of their drugs. Once the total cost of their drugs reaches $3,820, they go into that donut hole, or the coverage gap. This year, while they're in the donut hole, they're going to pay 25% of their brand name drugs, and they're going to pay 37% of their generic. And then to kind of keep it comparing apples to apples, once their total drug costs reach $8,417.60, they go into catastrophic coverage. And that's a bonus for folks because you only pay a 5% copay. But as I mentioned, Medicare is very fluid. We have changes coming. So starting next year, no more donut hole. Everybody is just going to pay a straight 25% copay for their drugs. So that's a nice benefit. This is just a representation of where we started closing the donut hole back in 2015 and then where we're going to be next year, again with that 25% copay. So we mentioned that there are penalties. So again, if you don't have creditable coverage, and I emphasize that because we did this boot camp about 10 days ago, and I had a handful of people come up afterwards and say, I'm in a penalty situation, but I have other coverage. No, you won't be in a penalty situation if you have other creditable coverage. So you'll have a late enrollment penalty if you don't have the creditable coverage, you didn't choose a Part D plan when you were first able. This penalty will be added on to the premium of whatever plan you choose. Okay? So the way that it's calculated is the penalty is 1% of the national base premium for every month that you could have been enrolled, but you chose not to be. So this year, the national base premium is $33.19. So really, we're looking at 33 cents a month is going to be your penalty for every month that you weren't enrolled. And that penalty amount changes every year, but minor swing. So they did some calculating, and this penalty went into effect back in June of 2006. So if you were eligible back in June of 2006 for Medicare Part D and you didn't get it, and now you decide this year you want to get it, your penalty is going to be $46.13. All right, that amount's going to be added to your premium. And again, the premium's about the average premium about $35 a month. So you're looking at what? $75, $80 a month. Now, I have counseled people who come to me and say, I understand that there's a penalty. I don't take any drugs. I don't want to pay a monthly premium to have a Part D plan to just hang out there. So I'm going to take a calculated risk, and I'll set aside some money, and I'll cover that penalty when the time comes. And they're fine with that. The only downside is if you get sick in the middle of the year, you have no prescription coverage, you've got to wait till the end of the year, and your coverage is not going to start until January. So you might be okay with the penalty, but you might not be okay with a very expensive drug that you're going to have no coverage for. So I said that there were what we call IRMAs, or income-related monthly adjusted amounts for B and D. So people who have some higher income are going to fall into this category, and they're going to have an additional amount added to their monthly premium. So this is kind of a breakdown, and it goes for Part B and D. Here it's just saying that it's Part D, but the numbers line up. So you're going to have these additional amounts added if your income falls into these categories. If we get to $750,000, I don't know that I'd be so upset about having an additional $77, but we have gotten some pushback from some of our people that we've counseled, and they say, well, I earned more, I paid more over the years, why do I now have to pay more? But as it stands now, there are these IRMAs for people who are in those higher income brackets. So when do we join a Part D plan? So we can do that when we are new to Medicare during that 7-month initial window. We can do that during the annual fall enrollment, which runs October 15th through December 7th, with coverage beginning in January. And then there are some special enrollment periods, and one that may affect some of our people is if you move outside of your planned service area. So for example, if somebody moves into a nursing home, they are then allowed to choose a new Part D plan that may align better with whatever plan they're using at the home. Joining is easy. Call the plan directly, go on their website, go to medicare.gov, simple enrollment. Let's talk a little bit about Advantage plans. So these are health plan options that are approved by Medicare, and as I mentioned, they're structured like an HMO or a PPO. HMOs are the most restrictive. For the most part, you cannot step out of network with an HMO and have any coverage. PPOs do give you the option of stepping out a little bit, but you pay a higher you pay a higher copay for that. These are run by private insurance companies. Interesting part about these is for every enrollee, the plan is paid a fee each month from the federal government. This is called a capitation fee. And that's why we see some of these HMOs that are zero premium. The plan is still getting paid, they just aren't getting a premium from the beneficiary. All right, this is just another way to get your Medicare benefits. You're still part of the Medicare program. Excuse me, you may have to stay within networks and use the network doctors, and most likely that's going to be the case. Interesting part about these as well is they don't travel well. So we have a lot of beneficiaries in Michigan who are snowbirds. So they get into an Advantage plan, they travel down to Florida or Arizona, and they have a medical emergency. An Advantage plan will cover that emergency. But let me tell you what happened to a client who called me. Husband and wife traveling to see their daughter out of state. The wife got out of the car after a long trip, fell and broke her hip. They took her to the hospital, and of course that was covered. But once she was ready to be discharged from the hospital, they wanted her to go to rehab. Well, she's out of network. She was out of state. So the option was go to rehab and privately pay, go back to your daughter's house and heal till you can get home, or find a way to get home right away. So what ended up happening is they spent a couple of weeks at their daughter's house letting her heal. They were able to get her home, and because she was within that 30-day window of being discharged from the hospital, she was able to go into rehab. But we lost, 2-3 weeks of rehab that she really needed. So these Advantage plans work fine for people who are on the healthier side, the younger side of Medicare. But the feedback I get from people who are in them is they were great until I got sick. And then they started nickel and diming me. Not to say that it's a bad product, it's not. It's just you have to be mindful of your situation. So as I mentioned, you're still in Medicare. You have all the rights, protections, and benefits that all Medicare beneficiaries are entitled to. You still get all the Part A and B services, but you still have to pay your Part B premium. And over the years, I've had a lot of people come to me and think that they've really figured it out. And they say, I'm going with an Advantage plan because I don't have to pay my Part B premium. You do. They still take it out. Doesn't matter how you get your Medicare, but a lot of people think that. Some of these plans include prescription drug component, some don't. If you choose one that doesn't have a prescription drug component, you don't have prescription drug coverage. You cannot purchase a standalone plan within a Medicare Advantage plan. They do offer, I maybe shouldn't say it this way, but kind of a hook with some extra benefits. And so over the years, you may hear on the radio when they advertise these policies and they'll say you'll get a dental benefit. And people say, well, that's great because Medicare doesn't cover dental. But if you look at the fine print of what that actually amounts to is it's really maybe 2 cleanings and 1 x-ray a year. It's not dentures, it's not bridges, it's not root canals, it's not all those expensive things that people are hoping it covers. And again, as I mentioned, there are always going to be copays and deductibles. So the sicker you are, the more you pay. So again, with enrollment, you can do this when you're first eligible for Medicare during that 7-month window. You can join from October 15 to December 7th during the annual enrollment. There are other times that you can join based on special circumstances. And again, this one's easy. You call the plan if you want to enroll. You can go on the website. You can go to medicare.gov. Again, with Medicare having changes all the time, this year they added what they're calling a Medicare open enrollment period for Advantage plans, and that runs from January 1 to March 31st. So what can you do during that time frame? You can switch from one like Advantage plan to another like Advantage plan, meaning if you had one with drug coverage, you got to switch to another one with drug coverage. You can switch from an Advantage plan to Original Medicare, but what you can't do is switch from Original Medicare to an Advantage plan. So this is just something they added that replaces what we used to call the disenrollment period. So, beginning in January, Medicare Advantage plans were given the green light to add some additional benefits to their plans. So they can cover Meals on Wheels, they can cover transportation to a doctor's office, wheelchair ramps, grab bars, those types of things that were not covered before. This is new. Each plan has been given the autonomy to set this up however they want, to offer whatever plan options they want. This got some of our advocacy groups up in arms because they said, that's great, we're offering these wonderful things to Medicare Advantage participants, but what about Original Medicare? Why aren't we offering this in Original Medicare? So this is a fight that's going on right now. We'll see how it ends, but they are definitely pushing back. So these are a continued list of what they can offer. And unfortunately, I can't give you a lot of feedback because this is new, and each plan is a little different, and I haven't had a lot of feedback from my beneficiaries yet as to how this works. So for example, adult daycare, what does that mean? Does that mean you get 1 day a week? Does that mean you get 1 week a year? Does that mean ongoing? We don't know that, and each plan, again, has the autonomy to decide that. So we're going to change gears a little bit and talk about a couple of programs within the MAP program, within what we're typically trained on, that can help some of our low-income folks. So we have the Extra Help program, Medicaid in the community, so full Medicaid, the Medicare Savings Program, and then a program called the Michigan Medigap Subsidy. So what's Extra Help? This is simply help paying for some of your prescription drug costs. There are a few groups of people who are automatically eligible for Extra Help. They also call it Low Income Subsidy, or LIS. Always have to make things confusing. But for those people who are duly eligible with both Medicare and Medicaid, they'll automatically receive Extra Help. Those who are receiving SSI, they'll automatically be enrolled. And then those who qualified for the Medicare Savings Program, which we're going to talk about, has more stringent guidelines, so they are also automatically eligible for this program. Easy application. You just call the Social Security Administration, you go online, do a quick application, takes about 20 minutes. Determination is made within about 10 days to 2 weeks. And there's no documentation required for this program. So these are just the different levels. As you can see, as you go down, you're allowed to have a little bit higher income and a little bit more assets, and the benefit reduces a little bit until we get to the end where you have a sliding scale premium, an $85 deductible, and a 15% copay on your drugs. So it is a big help for some of our low-income folks. They can get their prescriptions much more reasonably. So we're going to talk a little bit about Medicaid. I'm not going to steal Amy's thunder. She's going to come up and talk to you guys more in depth. But there is Medicaid programs in the community, one of them being full community Medicaid. But again, Medicaid is just health insurance for our low-income individuals. It's a state and federal partnership, okay? So the federal government provides funds. The states have autonomy to decide what their programs are going to look like. And they're also, they determine eligibility for the programs. So for most people who are duly eligible with both Medicare and Medicaid, most of their medical expenses are covered. And you know, we encourage people to apply. Even if you think you might be eligible, it's worth it, because once you submit that application, there may be other programs that you weren't aware of that you'll be qualified for. So the program that I was referring to is called AdCare, or Aged and Disabled Care, Full Community Medicaid. This acts as a secondary insurance to Medicare for those who can't afford supplemental insurance. And you can see the numbers, of course, are pretty low. So a little bit about the Medicare Savings Program. This is also referred to as MSP. This is help paying your Medicare premiums. And it may, at the highest benefit level, also pay your deductibles and copays. You're able to have a little higher income and resources, and of course those amounts change every year. So we have 3 levels. We refer to them as Quimby, Slimby, and Almby. So Quimby is the program that has the most stringent requirements. So you have, as you can see, each of these programs has the same asset limit, but the income is the lowest with the QMB or Quimby benefit. So this pays your Part B premium. So for these folks, it's going to leave $135 in their check each month, which can be a big help for our low-income seniors. And then it will also act as a secondary insurance. It's going to cover the copays and deductibles that Medicare doesn't pay. Then as we move down the Slimby benefit, all that's going to do is pay your Part B premium. But again, if you're low income, $135 is kind of a nice benefit. And the difference between Slimby and Almby is that Slimby is considered an entitlement program and Almby isn't. So that means if the money runs out for Almby, no new beneficiaries will be taken on. The ones who are in the program will remain in the program, but no new beneficiaries. I've only seen the program closed once, so I don't think it happens often. Usually there's funds. So this application process is a little tougher. It's a full Medicaid application. You can either do a paper application or you can go online. Again, Department of Health and Human Services kind of prefers that online option, but they have to take your application in any form that they get it. You can mail it, fax it, drop it off. There are proofs required here, so basically anything that you answer yes to, you have to back up with documentation. Talk a little bit about the Michigan Medigap Subsidy Program. So this program began, how many of you guys had clients or are familiar with the Blue Cross Blue Shield Legacy product that we used to have? So that was a great benefit. We had a subsidized Medigap offering in Michigan for a number of years, and it was offered through Blue Cross Blue Shield. Well, a few years ago, Blue Cross Blue Shield decided to change from a nonprofit to a mutual. And when they did that, they were allowed to raise their rates to market rate. So what that meant for a lot of beneficiaries in Michigan is that their premiums, in some cases, doubled and even tripled. So the terms of Blue Cross getting out of this contract were that they had to contribute 1% of their group health sales to this Medigap subsidy. So it kind of eased the transition for people who were used to paying a very small premium and now had a very large premium. So we'll see how that looks. So to qualify for this, you have to be a Michigan resident, and that just means that you have to live in Michigan for at least 6 months out of the year. And if your household income falls into the two numbers that we have up there, you're going to be eligible for this program. The other qualification is that you have to be enrolled in one of these 5 plans. So you have to get your Medigap coverage through one of these 5 listed plans. So the subsidy, if you are age 65 to 75 and you qualify, it's going to reduce your premium, your Medigap premium, by $35 a month. If you are over age 75, it's going to reduce your premium by $56 a month. And if you're disabled, under 65, it's going to reduce your premium by $110 a month. Again, this is an easy application. You can call and do this by phone, or you can download their application and turn it in that way. So this program is guaranteed to be funded through 2021. They don't have an exact end date because it depends on how many people take advantage of this benefit. It is a finite pool of funds. Once it's gone, and unfortunately, the premiums will then go up. Once you're approved, you're in this until the program ends, so there's no reapplying. Okay, Medicare fraud. I feel like we have to take a minute and talk about Medicare fraud because it's huge. Give you a little history of kind of what's going on. So Medicare fraud became a really big issue some years ago down in Miami. We saw a lot of fraudsters doing a lot of crazy things down there. And they set up a task force to clean up this fraud issue. And when they did that, the fraudsters looked around and said, where do we go from here? And they came to Detroit. So what they did was, what we initially saw was there's a place in downtown Detroit in the Cass Corridor, and it's called The Beach. And it's where homeless folks go to wait for day labor jobs. So we know that our Medicare beneficiaries are fairly easily identifiable by their appearance. And so these fraudsters would come to the beach, and they would look at anyone who might look like they were eligible for Medicare, and they would say, are you willing to sell me your Medicare numbers? Well, these folks are homeless, they don't have any money, they're offering them $50, $100. It sounds like a good deal. So they have these individuals sign a lot of releases so that providers, unscrupulous providers, can then bill for services that were never provided using their Medicare numbers. Doesn't sound so bad. These people got $50, $100, but the downside for them is they get sick. And they go to the hospital and they need a test or they need a procedure, and Medicare says, you've already been billed. We've already used your number. That's already been billed. We can't cover your services. So they found out the hard way that selling their number really didn't work out in the $50 to $100 range. So, but we are kind of all responsible for keeping an eye on fraud so that we can continue the Medicare program for future generations. So I said that there was, excuse me, a task force that was set up in Miami. We set one up here now. Continues to grow. The task force that we have here was responsible for catching, I guess, lack of a better term, Dr. Feda, who was that oncologist who offered all of those treatments out to people who maybe didn't even have cancer. So this task force was able to apprehend Dr. Feda and get restitution, and of course that doesn't bring back the people that he harmed, but just to give you an idea, it is an ongoing issue here. So we want people to, well, let me see if I can go forward. we want people to pay attention to their explanation of benefits and to their Medicare summary notices. And if they see something that doesn't make sense, like billing for a doctor they never saw, or billing for a date that they know they weren't at the doctor's office, we want to encourage them to report this. They can call Medicare and report this directly. And what will happen is all of these are sent to the task force, and they then go through and start to see if they can establish some patterns with particular providers. And if they start to see a pattern that's not lining up, they're going to then pursue that provider. They can't go after everybody. There's too much fraud going on. Some of the small players fly under the radar, but some of the big ones, they're going to catch, and they're going to get the restitution. Medicare has switched from what used to be called a pay and chase method, where they paid the claims and then found out later they were fraudulent and tried to chase the money back down. We know that doesn't work very well. So Medicare has moved to a real-time billing system so that they can kind of see what's going on, catch fraud before it becomes a real big issue. So if you still want more information about Medicare, you can go to medicare.gov. Medicare's site has been improved quite a bit over the years, and there's a lot of good information on it, so certainly do use that. There's always a Medicare and You handbook that's issued every year. This handbook is available online, but it'll be mailed to our Medicare beneficiaries directly. And then you can always call 1-800-MEDICARE. You get some of your more basic questions answered that way. There's also the MAP department, which I still am involved in, so that's the Medicare Medicaid Assistance Program. And that does offer non-biased counselors who can meet and talk with our Medicare beneficiaries, answer their questions. They have nothing to sell, so you can get an unbiased opinion there. So in the interest of you guys having your full lunch hour, I'm not going to be able to take questions right now, but feel free to see me at the table if something didn't make sense or you have additional questions. I'll be around for the rest of the day, and I am happy to answer your questions. So thank you for your time, and we will be available.
Again, I know we had a couple of questions in the audience. After this next presentation, Lisa's going to be at this table. Please feel free to come up to her and ask her your questions.